So I think we can start. Welcome to this side event. I'm Eloisa Bergiato. Welcome to this side event, Improving Equitable Global Availability and Affordability of Internationally Controlled Essential Medicines in Africa through interagency, member state, and civil society collaborations. This side event is organized by the International Association for Hospice and Palliative Care, a global organization with 1,350 members in 140 countries. First, I want to thank the missions of South Africa, Ghana, and Belgium for co-sponsoring this side event. We also thank the INCB, UNODC, and all civil society co-sponsors. We welcome all participants in the room and those joining online, including some panelists from Ghana, South Africa, and Uganda. Each panelist will have 5 minutes, and I will be strict on time. The IAHPC had a memorandum of understanding with the INCB aimed at improving availability of controlled medicines where needed. And now I'm going to introduce Dr. Atasoy, who is a member of the International Narcotics Control Board and professor of biochemistry and forensic science, vice-rector and director, Institute of Addiction and Forensic Science. We are hoping you to tell us about the INCB learning program as a tool to improve availability and affordability of controlled medicines in Africa. Dr. Atasoy, you have the floor.
Thank you very much. Well, I think I will not stick on the framework that you imposed me because
no, I don't impose.
because I want to speak one much broader issue, our collaboration with the IAHPC and INCB, which is first in this century. Well, Excellencies, ladies and gentlemen, I would like to commence by expressing my appreciation to the International Association for Hospice and Palliative Care for organizing this side event and for inviting the International Narcotics Control Board. In November 2024, IAHPC and INCBs signed a memorandum of understanding that provides for an institutional framework of cooperation to improve the availability of internationally controlled substances for medical and scientific purposes. The objectives include, among others, an annual exchange of research, data, and analysis on controlled medicines, as well as the exploration of possible solutions, such as joint activities to make the information available to the international community. This side event is part of that understanding, and it is a pleasure for me to participate on behalf of INCB. Even though the availability of drugs for medical and scientific purposes is recognized as indispensable in the conventions, the reality is that of imbalance and an extreme gap in the capacity of countries to fulfill this requirement. Data provided by governments to the INCB have for a number of years confirmed the persistent inequalities in access to opioid-based pain medicines. Almost all consumption of these opioid analgesics is concentrated in Western Europe, North America, and Oceania, essentially Australia and New Zealand. Levels of consumption in other regions are insufficient to adequately meet medical needs. In 2023, the latest year for which statistics are available, this was of particular concern in East and Southeast Asia, Central America and the Caribbean, South Asia, and Africa. These regional imbalances are not due to any shortages of raw materials. Global supply is more than sufficient to meet the demand reported to INCB by governments. However, the estimated requirements for several countries may not accurately reflect actual medical needs. INCB has urged opioid manufacturing countries to increase the manufacture of morphine preparations for use in pain management and palliative care, and also to make them more broadly available and more affordable, in particular in low and middle income countries. While morphine has historically been the most readily available and affordable opioid analgesic for pain relief and palliative care, largely considered the gold standard. And although most countries and territories reported consumption of morphine in 2023, many people still have limited access to it. One factor contributing to this problem is that more than 80% of morphine manufactured worldwide is not utilized directly for pain relief, but rather for the manufacture of other substances, such as codeine. That leaves about 33 tons of morphine annually consumed directly for palliative care, mostly in high-income countries. Only 4.75 tons are consumed in middle and low-income countries. Other factors, such as economic and commercial interests, knowledge and training, as well as regulatory frameworks, influence the ability of countries to procure and administer morphine for pain treatment. Before I conclude, allow me to briefly address the issue of access to internationally controlled substances for medical purposes during humanitarian emergencies caused by armed conflict. This constitutes one of the most pressing challenges faced by the international community today, and challenges are posed by ongoing violence, logistical challenges, and political constraints. The drug control conventions allow for the expedited movement of controlled substances for medical use during emergencies. Competent national authorities may permit the export of medicines containing narcotic drugs and psychotropic substances to affected areas in absence of the corresponding import authorization or estimate, and urgent deliveries do not need to be included in the estimates of the receiving country. I congratulate IAHPC for its continuous work to ensure the availability of opioid analgesics for pain relief and for being a valued partner of INCB in this important effort. Thank you.
Thank you. Thank you. Now, Ghana is one of the co-sponsors of this webinar. And now it is my pleasure to introduce the civil society representative, Ms. Maria Goretti Lopez, a Ghanaian lawyer who serves as the International Drug Policy Consortium's African consultant. She advocates for human rights and comprehensive drug policy reform, promoting inclusivity and equity in Africa and beyond. Maria Goretti is also one of the drafters of the West African Model Drug Law for provisions of essential medicines. Please tell us how this law can help member states ensure affordable availability of controlled medicine.
Thank you very much. Thanks so much for giving us the opportunity to be part of this conversation. Just to give a little bit context, especially those who might not have heard about the West African Drug Policy Commission as well as the Model Drug Law. So the Model Drug Law was developed by the West African Commission of Drugs in 2018. And basically this Model Drug Law sets the framework for policy within the region as to how it can guide member states in developing and improving upon their drug policy. For the purpose of those who don't know much about the commission itself, it was actually convened by the late Kofi Annan, and it was chaired by the former president of Nigeria, His Excellency Olusegun Obasanjo. It also draws a number of renowned former presidents and former prime ministers within the region, and also people from the world of politics, civil society, health security, and the judiciary. Basically, the commission found that there was actually a problem within the region in terms of drugs and policies. And so there was a need for them to focus on this and see how the commission can support in terms of improving things by looking at the health-centered approach and evidence-based practices to combat drug abuse within the region. Now, during the commission's work, they undertook a number of country visits to engage with many countries and to be able to find out what the challenges were. And they basically came out with a report, which was known as Not Just in Transit. And in this report, it highlighted a number of things. And one of the key things that was also observed was the issue of essential medicines, especially lack of it within the region. The commission also observed that within West Africa, there was a great disparity in terms of access to essential medicine, especially within the Francophone and Anglophone countries, with Francophone and Francophone countries really lacking in terms of availability of essential medicine for pain management within the region. And they also found out that close to about 33 countries in the region have no honesty in terms of addressing issues around drug use. Now, apart from the issue around lack of essential medicine itself, they also found out that there were quite a number of barriers that were serving as a means by which many countries were not able to fulfill these obligations. One of these barriers was that there's overly restrictive regulations, and so that actually kind of inadvertently limited access to essential medicine. There was also a clear indication of colonial legacies, in the sense that this kind of further entrenched the inequities within the country, within the region, in terms of inheriting weak health systems, undeveloped pharmaceutical sectors, and limited regulatory capacity for the drug administrators. This was also one other thing that they found, that it looks like there's so much opioid phobia in terms of prescriptions. So it was something that we needed to address around that. So basically, if you take the Model Drug Law, it's like, in terms of the provisions, it emphasizes on core objectives of the conventions as to making sure that there are these substances are available for medical and scientific purposes, while focusing on the availability for medical use. There were key issues that they found out in terms of these particular business within the countries, and also how countries can leverage on the Model Drug Law to be able to do that. So the Model Drug Law actually acknowledges that the restrictive regulations and the fear of prosecution among healthcare providers have led to inadequate pain management within the region. And so it sort of serves as a guide on how states can enable greater use of the controlled medicines, as well as giving health professionals the freedom and the confidence to be able to perform their duties without fear of unjust arrest. The Model Drug Law also proposes that we need legal protection for medical professionals, especially prescribing these medicines, aiming to remove barriers to effectively be able to make pain management medications available for use judiciously. Now, countries were also urged within the Model Drug Law to try and set up what we call the commission, like a kind of constitute a commission that is basically to look at improving access to essential medicines in terms of using the Ministry of Health as an oversight ministry responsible for this. Because when you realize that most of the times in our countries, discussions around drugs basically is driven by the drug agencies. And so it was important for us to begin to incorporate this and see how the Ministry of Health can also play an oversight responsibility in doing that. And for them, they believe that doing so will help us to be able to improve upon a lot of these challenges that we are also facing as a country, as a region, and also the need for educating healthcare professionals in pain management and drug treatment in terms of how these opiates can be used as cure to most of these challenges. I want to really wrap up so that we don't take much of the time. And so for us, we believe that the model drug law is actually a tool that can help a lot of countries within the region to be able to leverage on it and then improve upon access to medicines by improving upon their drug laws and amending them to address that.
Thank you. Thank you very much. Now our next speaker is joining us online, our IAHPC colleague from Ghana. So I'm pleased to introduce Dr. Cynthia Poma Akuku, a nurse educator and researcher in palliative care, who will brief us about the situation regarding availability and affordability of controlled medicines in her country. Dr. Akuku, you have the floor to tell us about your experience.
Okay, thank you very much for this opportunity, and greetings from Ghana. So this is just to talk briefly about the availability, accessibility, and affordability of these controlled opioids, especially when it comes to palliative care. Within Ghana, we are still trying to integrate palliative care within the health facility, especially the primary health care facility. Aside the main teaching hospitals where we have well-established palliative care units attached to them, when you go to the regional hospitals, most of the regional hospitals and the district hospitals, we are yet to set up these palliative care units. Now with the Ghana College of Nurses and Midwives training more palliative care specialists, nurse specialists, they are able to go back to their various facilities, and now we have some of the health centers even trying to set up palliative care to help people who need these sort of services. Now, when it comes to the controlled opioids or the narcotics, their availability in Ghana here, we have some of these medications being available to them. So we will start by looking at morphine. So morphine in Ghana here, we have the syrup, the tablets, and the IV being available in the country. For the morphine IV, is being covered by the National Health Insurance and is available in most hospitals. However, the quantity available may vary depending on the hospital procurement policies or system. Sometimes it runs out of stock, and in most primary facilities, and patients will have to buy out of pocket. Not only available in the teaching hospital, but also the IV morphine available in the community pharmacies, but not in the chemist shop that are mostly found within our communities, because these shops are being attended to by unqualified and unprofessional pharmacists. So they just have sales attendants attending to such chemist shops. So they don't have the IV morphines there, but we can find them in the bigger community pharmacies. When it comes to the syrup morphine, is being covered by the National Health Insurance. And sometimes it costs about between $5 to for about 100 ml a bottle, which for majority of the patients may last for 3 to 6 days. And it is more expensive in the primary pharmacies. That is those pharmacies that are outside the teaching hospitals or produced by pharmacies of the teaching hospital from the imported powder. The primary pharmacies, they buy these medication from imported, they import them from countries like UK, so the prices are very expensive. They are twice as much as the ones that they get from the teaching and hospital, all because it's not being covered by under the national health insurance. And the reason they give to it is that because it's a control drug, so they don't want it to be available whereby anybody can just purchase these medications like the paracetamol we purchase over the counter drugs. So it's a major barrier to patients with chronic pain when it comes to Ghana, especially those with cancer, and when we are managing them under palliative care. So sometimes they have to endure the pain and take lower doses or increase the time between the doses for the drug to last a little longer. But when it comes to medications like the fentanyl patch, it's not commonly available. Sometimes only few pharmacies may have stock in the entire country, and that is either in Accra or Kumasi. Recently, there was none available in Kumasi, and patients have to request it from Accra, and they also add extra costs because they had to be delivering these medication through the airlines, and we know that is not very, very cheap. Secondly, the patches, it comes in about 50 microgram per hour, and is what is normally seen in the country or what they normally prescribe. Most patients don't need that much, but because that is what is available, so when they are being switched for morphine to fentanyl patch, that's what is available, so that's what they get. Usually it's the 12.5 microgram or 25 microgram patch that most people need, but that is unavailable in the country. For the IV fentanyl, it's available mostly in hospital ICU pharmacies, but cannot be given outside the hospital. So when you want that one, it cannot be given. But for the lozenges, that is not available at all in the country. And few pharmacy shops also stock the oxycodone tablets. So that is also very difficult to come by. Now, when it comes to tramadol and codeine, they are available in most pharmacies in different preparations, sometimes combined with paracetamol to manage the pain that patients go through. Some brands are expensive, but relatively affordable brands too are available for patients to also access these medications. So lastly, when it comes to the methadone, that one is not generally available in the country, and patients do not have access. If you want to have access, then it means you have to import it from outside the country. So I think the recommendation would be that there should be coverage of especially the syrup morphine, which is available or common in our setting here under the National Health Insurance, just as it has been done in Uganda. So we can copy a similar system here in Ghana to help patients get access to these pain medication.
Yeah. Thank you, Cynthia. South Africa is another sponsor of this webinar, and they have nominated as their speaker Mr. Lawrence Mandikiana, who is joining us online from Johannesburg. Mr. Mandikiana is Deputy Director for Palliative Care at the National Department of Health, South Africa. Is he online?
Thank you, and a very good afternoon to everyone, and greetings are being sent from South Africa. Thank you so much for this opportunity. I'm just going to be presenting to us the current status quo of palliative care in South Africa. Next slide, please. So South Africa has a population of around 63 million. And then you can realize that 84% of this population, they rely on the national health, public health system. And then with 8.5% of our GDP comprising, coming mainly from the health budget. Next slide. And then looking into the definition of palliative care, we can't talk of palliative care without the relieving of suffering. So I think one of the good things which is happening in South Africa is we are mainly focusing in terms of making the quality of life for our patients comfortable through the availability of essential medicines. Next slide. So the general challenges in accessing palliative medicines around the world, according to literature search, is the issue of need versus supply. As our previous colleagues have mentioned from Ghana, there is that need in Africa whereby 80% of those who require opioids, they do not have access to it, with only 20% accessing such services. And then stigma and awareness is of rampant importance in Africa because of people not having enough education in terms of opioids and then near-death experiences, whereby when you are believed to be taking morphine, you are also nearing death. Next slide, please. So to counter this now, the National Policy and Framework for Palliative Care was introduced in South Africa. So it's a policy framework which is mainly guiding the government and healthcare practitioners and facilities in terms of how, essential things like medicine can be accessible to everyone. Next slide. So to make this a reality, the government came up with the Essential Drug Program. So the Essential Drug Program, the main objective of this program is to come up with standardized treatment guidelines as well as essential medicines list. And then this component makes sure that there is equitable access to medicine to all citizens of South Africa, and then at affordable prices, and at the same time, the medicines should be readily available in all the healthcare facilities. Next slide, please. So the issue of essential drug program also makes sure that there are essential components and should I say symptoms which needs to be treated. And we've seen that palliative care falls there, terminal care also falls there. So all presenting symptoms, we have to make sure that there is availability of medicines for these symptoms. Next slide. So coming to the issue of availability, this is the current landscape in our country. So availability of medicines, it's readily available everywhere in all the facilities. We do not have, although sometimes, you can have erratic stock outs, but that accounts to the facility pharmacist maybe of not ordering in time, and then the lag time between supply and order are not adhered to. And then in terms of accessibility, there are good distribution profiles within the country. Always make sure that those in underserved communities as well as rural communities, they've got good access for palliative medicine. And affordability, the government has good budgets for essential medicines and opioids, so we can't really account that extra cost to our patients because that is readily accessible free of charge from our healthcare facilities. Next slide. So we have a patient case which we have here. I've just outed the name of the patient. Her name is Naomi, 2 years, but this is an actual case which took place in one of our facilities, diagnosed with neuroblastoma in her abdomen. And then she was actually a smart little girl. She also participated in decision making in terms of her opioid, and then she was onto morphine syrup. And then later on, when her disease advanced, she was now into IV, and then a syringe driver was inserted, and then as well as she died before her 3rd birthday, but she also died in the comfort of her family and without pain. Next slide, please. So in terms of our recommendations from South Africa, there is need to strengthen supply chains, make sure that there are uninterrupted availability of essential medicines, also to improve affordability. I think one thing which we are doing well in South Africa is bulk buying, also using internationally recognized suppliers where our prices for morphine are so reasonable. For example, 15 milligram for IV, it costs around 40 US dollars cents, which is much more reasonable compared to other countries in Africa. Next slide, please. And then our take-home message to everyone is let's always make sure that we advocate that access to palliative medicine, it's a right and it's not a privilege. Thank you so much.
Thank you very much, Lawrence. And now it's my pleasure to introduce Dr. Stephen Oliver, a medical doctor from Kenya, a representative of the UNODC Young Doctors Network. Dr. Stephen, please tell us about the availability and about affordability of controlled medicines in Kenya. You have the floor.
Okay, thank you very much for that introduction. So as you've heard, my name is Dr. Stephen from the United Nations Office of Drugs and Crime Young Doctors Network. And our work as the Young Doctors Network, the informal group of the UNODC, is to protect the population that needs these particular controlled drugs. That is the patients who are in for palliative care, the cancer patients, the surgical patients who may be in need of this drug for pain medication. And my area of focus will be mostly on policies and the other work that we do as the Young Doctors Network. The 67th session of the Commission for Narcotic Drugs, plenary, the Young Doctors Network shared a statement, which was called Statement by the UNODC Young Doctors Network on Access to Controlled Drugs. This statement was prepared by the members in collaboration with the UNODC and proposed 5 recommendations. One of them was to strengthen education and training in rational prescribing of controlled substances, foster global partnerships to share best practices and innovations, to advocate for policy reforms, to balance access to controlled medicines and prevent misuse, to support research and data sharing to inform evidence-based policy making, to address stigma around controlled medicines and ensure equitable access to them, particularly in low and middle income countries. That is a statement that we delivered last year, and we are looking forward to delivering also a statement in the 68th session. So at the policy level, at the international level, we want also to improve access of controlled drugs to the population that needs it, the palliative care patients, the cancer patients, and for pain medication. So giving you an example of where I come from, which is Kenya, and the policies that affect the country, the policies that affect the prescription, the access and availability in Kenya. Maybe we can move to the next slide. During the 2019 census, Kenya's population was at 47.6 million. And in 2021, this is a geospatial or geocoded information and spatial analysis of the healthcare facilities in Kenya. We have the private sector and we have the public sector. And this is access in terms of how fast you can reach at the nearest health facility within 60 minutes, within 1 to 2 hours, and after 1 and after 2 hours. So you can see the public health sector's green means the people who are able to get access to the health facility within 60 minutes, and then the yellow within 1 to 2 hours, and then the red more than 120 minutes. And they looked at about 12,000 healthcare facilities in the entire country, of which the public facilities were about 7,000 and the private were about 5,000. So with this data, you can get convinced that there is at least a healthcare facility in each region in Kenya. But the question that comes into mind is, do we have controlled drugs in those particular facilities? When these patients need pain medications or opioid for any other reason, will they be able to get access? So my next slide will be on the regulations and the policies and the laws that govern the accessibility, affordability, and availability of these particular medications in these particular healthcare facilities. Next slide. So you can see the government laws. The supreme law of Kenya is the Constitution of Kenya 2010. So from this particular law, every sector, whether it is agriculture, transport, education, health, can enact their particular laws from that particular, supreme law. The law that governs the controlled drugs is the Narcotics, Drugs, and Psychotropic Substances Act. It was enacted in 1994, and then it was revised in 2012 and recently in 2022. So we also have the Kenya Health Act that governs the entire health ministry. And then now for palliative care, we have the Kenya Palliative Care Policy 2021-2030. One thing I want to say about this policy is that it has to align to the Narcotics, Drugs, and Psychotropic Substances Act. It has to align to the Constitution of Kenya, and it has to be within the frameworks of Kenya Health Act. So even though it's a policy, but it has to be within the already existing laws. So even if you were to come up with anything that will improve access, you must first of all do it at the law-making level. We also have the Pharmacy and Poisons Board Act, is the one that regulates the pharmaceutical products and the health technologies in the country. We have the Medical Practitioners and Dentists Act. And one thing I want to highlight from this act is the one that defines a doctor, defines a dentist. And then the Kenya Palliative, the Narcotics, Drugs, Psychotropic Substances Act actually limits the prescription of controlled substances to doctors and dentists. Okay, so the Pharmacy and Poisons Board Act is the one who defines who a dentist is and who a doctor is, and is the one also that regulates training of medical doctors and dentists. And then we have the National Authority for the Campaign Against Alcohol and Drug Abuse. So this is now the act, the government law that now deals with the non-medical use of controlled substances, the drug trafficking, the drug abuse. So one thing I want to maybe highlight from this presentation is that the laws are very many. So if you are a doctor, you are worried more of the law than what you need to prescribe. And since you don't know what the law says, you'd rather prescribe other medications because you don't know what happens, what is going to happen should a problem occur. Because the laws that govern the controlled medicines, you can see this, I didn't exhaust all of them. We also have the penal code that lists all the punishments that whoever contravenes the law should get. So you will find doctors in Kenya, because the regulations are very many, they would rather just prescribe other medications because they don't know what is going to happen. And this is just one country that is being affected by the policies, the laws, and everything. When you talk about the affordability in Kenya, now that we are talking about Kenya, we have what we call the Social Health Insurance Fund. And some of the controlled drugs, if I may use morphine, is available in public facilities at level 4 level. We have level 2, level 3, level 4, and level 5. Those are tertiary institutions, and level 6. So you find if you are under the national cover, it will cover for morphine and a few controlled drugs. And of course, as I wind up, I also want to highlight the fact that Kenya, we have also local manufacturers of various pharmaceutical products. We have about 35 licensed companies that are able to manufacture local products, but there are also very strict laws and regulations that govern that particular industry. Thank you very much.
Thank you. Now our final speaker from Africa, who is joining online from Kampala, is Dr. Mark Beziga, Executive Director of the Palliative Care Association for Uganda. Mr. Beziga, we look forward to hearing you about how Uganda model is making morphine affordable and available at the population level, as well as the challenges that you are currently facing. Mr. Beziga, you have the floor, and our tech will advance your slide.
Yes.
Yeah, thank you so much, and for the opportunity to be at the meeting today. We I'm grateful to the IAHPC and all friends who continue to invite us. I'll be sharing about our experience in Uganda very briefly, and I know that perhaps people in the room have a few slides that I put together and shared with you. We, as the Palliative Care Association of Uganda, coordinate the palliative care providers in the country, whereas Uganda is given as a good example in many of the slides that we've just been spoken about, or the presenters that have just presented. That was supposed to be my very last slide, the one that is showing on the screen. We still have very few hospices and home care programs in our country. For all the literature that you are able to access, you'll see that the hospices are less than 20 for a population of 46 million people. We still have, and yet we have many people in our country living in poverty, 41% of our population. We see a rise, of course, like in all other places, on the incidence and prevalence of disease, especially non-communicable diseases. And we are sure that the trajectory has been that we continue to see palliative care services spread out and spread to different districts, but we still have about 40 districts without any single health facility offering palliative care. As a country, since 1993, when we started the journey of palliative care, and I'm glad I saw Dr. Anne Merriman online, who is the champion and pioneer of palliative care services in our country. The service received goodwill from the government, from the Minister of Health especially, and so the government allowed Dr. Anne Merriman to bring in the morphine, the oral liquid morphine solution, and that's what I'll emphasize. And from that time in 1993, there has been tremendous progress in making sure that the patients can access this oral liquid morphine for free, or they can access it affordably at health facilities. And so our government pays for the reconstitution of oral liquid morphine, which is manufactured at the Hospice Africa Uganda, which is a hospice. And we are very grateful that that's done at a hospice, because that means that it is manufactured or reconstituted by people who are passionate and who are compassionate and who know the need, paid by the government. It is distributed through the national medical stores to government facilities, which are about 300, and then to the private facilities by the joint medical stores. And none of these distributors puts the cost or the charge to the patients when it reaches them. There are many factors that have contributed to that kind of success of being able to reconstitute morphine and distribute it to the facilities, much as we are not yet to all facilities that we want. One of them is the led advocacy by the champions, like I spoke about Dr. Annie Merriman, with the rest of the people that have been champions, and they have been at it, and so they have been able to galvanize their energy and speak to government and speak to the community, and people hear them. We have had a law that allowed nurses who are specially trained to prescribe oral liquid morphine for many years. We've had government funding, as I have told you, for the reconstitution, but not necessarily for the entire cost of medicine, because our out-of-pocket expenditure for an average Ugandan is over 40% for all the services they will have, because we are not yet having a national health insurance. We have had to engage different stakeholders. You'll find us, we work as the National Association of Palliative Care, we work with the Anti-Narcotic Department of the Police, we work with Ministry of Internal Affairs, we work with Ministry of Foreign Affairs, we work with different actors to make sure that everybody is aware of what's happening. We have very good collaborations and partnership between standalone hospices as well as government hospitals. So government hospitals will discharge their patients through hospices who go home, and we continue to make sure that we onboard the number of people who are trained and qualified in the communities. And we are, of course, lucky that we have a training institute, which is the Institute of Hospice and Palliative Care in Africa, which continues to train more people to come to the community. The challenges, of course, are various. the number of trained people are still very low. We still face myths and misconceptions about the use of the medicine, just like the people have said. We still have low data and M&E frameworks. We still have low funding for advocacy work to make sure that this controlled medicine reaches everybody. And then we have this global phenomenon that continues to threaten our work in terms of the global North drug signal and problem that continues to send signals to us. And so we see cuts in funding, in direct funding for supporting the morphine supply chain, etc. But we are always making sure that we have a partnership meeting at Ministry of Health coordinated by the Civil Society Palliative Care Association, where we continue to bring organizations together. In one of my slides, I had put a very good illustration of what it means for a palliative care patient in the community down there. And one of these patients was seen in 2019, just before COVID-19. And the story was carried by the Observer newspaper and then the Daily Monitor. And this is the caption. The caption was, apart from the Bible and the rosaries that were on the table for this patient named Rurega, the next item that was on the table near his bed were his bottles of oral liquid morphine. In the circumstances where people are poor, they report late for diagnosis, they are treated at end stage for most of the disease or for cancers specifically, you'll find that the ultimate need is that their pain is controlled and they have comfort at that level. As we move along, we continue to see, for example, the recent donor cuts, and the US has had a freeze on a number of projects. We hope that will be lifted, or if it's not, then it will have great impact. We have, and I put this slide, that we have over 29,000 US supported workers within the HIV, in TB, and in hospitals who are now currently on hold for the work. And whereas these are not directly to be palliative care providers, you find that they touch the core of the service. There are lots of resources on access to controlled medicine in Uganda. The Narcotic and Psychotropic Substance Control Act, we also have one. It's been challenged over time, and whenever we go back to Parliament and it is challenged by different sections of people, as palliative care people, we normally come straight and we are at the table with Parliament because we have been able to bring on board all of them and they clearly understand our point of view. So our matters are not contentious. But the doctors, the nurses, and those who prescribe still, of course, fear the law because it is always amplified on control more than on being able to be available for medical and scientific use. So we need to do our best to make sure that the message on need is up there, that people can listen to it, that the message that we need in Africa and in Uganda in particular is people to access the medicine for their pain control, and not necessarily the message to curb and control addictions, which we normally, by the way, don't see as much in this area where people are seeking medicine for treatment, but those who use and inject drugs are people who are not necessarily those in need of palliative care. As I conclude, I thank you so much, and I hope that we continue to engage and to continue to learn and to continue to make sure that those who are in pain and need this medicine can access it. I thank you.
Thank you very much. Sorry about our technical problem, but now we are going to continue. Finally, I'm happy to introduce my IAHPC colleague, Dr. Tanya Pastrana, who is our Education and Research Advisor, as well as the Assistant Professor for the Global Palliative Care at the Department of Palliative Medicine at the University Hospital Aachen in Germany. She will present some costing of controlled medicines in Ghana based on the IAHPC Opioid Price Watch project. Dr. Pastrana, you have the floor.
Thank you very much. And thank you very much to you all that are here in these many possibilities and to hear us. Thank you very much. I hope I get your 5-minute attention. I will speak about the affordability because it was the scope of this intervention. And please, go ahead. Okay, in the new estimations about the number of people experiencing cell related suffering, which you have already heard, indicate an increase to approximately 73 million people living and dying in suffering. Most of them because pain or because dyspnea. They are the most important symptoms for that. It was a huge increase, about 75% since 1990. And as you see, there are people crying there. If you can see the image of the picture. Next. Unfortunately, this distribution is not equal, like many things in our world. According to this study, which was published last week in the Lancet Global Health, that's next, please. In Sub-Saharan Africa, the amount of people needing palliative care increased from 8 million to 19 million. That means 20% from the world burden of suffering to 25%. That means 1 of every 10 people, 4 people is in Africa with suffering, in Sub-Saharan Africa. Despite this population, is only the 50% of the world population, as we see in the next one. In the International Association for Palliative Care, together with the group of Global Palliative Care Access, we are looking for the essential and expanded package. The essential package was developed by the Lancet Commission, thinking about what is the minimum that can be relieve this suffering, thinking about especially. And a group of people in children palliative care, they look at the package, and the package is composed of these dry things, medicines, equipment, and personnel. This is not just medicine, this is also we need equipment and we need personnel who are trained. In the bed essential package, next, please, we have in both morphine, morphine immediate release and injectable, the next one. And in the extended package, which is where the countries can afford, or the healthcare system is possible to buy something different. Next one. We include fentanyl, methadone, oxycodone, tramadol, and morphine, and for the adults, too, as a similar medication. That means it should be morphine in the release and injectable at least, and then if possible, the other one for rotation or for other needs. Please. Making some maths calculation. We are speaking about affordability, and I got some information from my colleagues from Ghana. Can you got? When we choose one day, okay, next, we calculate the 100 milligrams per day as an hypothetical statistical measure. Next is just hypothetical. We know people who are working in palliative care, some people need less, some people need more, but approximately 100 milligrams. Next. And 1 tablet, 10 milligrams morphine in Ghana, according with my colleagues, it costs $38 US. Next. This means for 1 day would be 3.8. Yes. Next. But for 50 days means $115 for 1 month. Next. Thinking about the 100 milligrams. But I don't know if you know, the minimum wage in Ghana is 1.16 US per day. What means that? For 50 days next, for 50 days treatment, people should give the 99 days of the one month earn for just one medication. And there is many other things that are in this month. Yeah, so I say other medications, equipment, etc. Also, next one, having the same calculation, according with the information that colleagues from me give me from Ghana. Next, you can see that how many days should people work in order to get 1 month for the other substance. We know morphine, I said immediate release and the pulse are essential, and the other are also as essential, are listed in the essential medicine list of the WHO. The other opioids, okay, that is the other. And as you say, there are some few medications which are covered by the National Health Insurance, which is good, as the people have to pay for that. But what I read is that approximately 65% of the people are covered by this institution. And the most vulnerable people, as the people they are most in need, they are not covered. Yeah, they are not covered. Also, next one. I want to say the service health offering is increasing, and the symptoms, especially pain and dyspnea, and we know the medication. This is not very expensive, and it's a good medication if you know how to use it in the case when it's needed. And that's enough to relieve these symptoms in most of the cases. So I work in a hospital cases, and it's not always, and beyond ensuring the availability in the countries, should be mechanisms that must be established to make medication not just available, but also affordable. Because if there's like a cake behind the glass, and so that people are able to pay for that without getting financial trouble. Thank you very much for your attention. I'm happy to have some questions later.
Thank you. We have 4 minutes left. Maybe you have time for one question. Ladies first, please.
It's not a question. I wasn't going to say much, but after listening to our colleague here, giving us an insight on Ghana's working usage, I'm sorry I missed the presentations from my country. My name is Matilda. I'm the ambassador of Ghana here, the PR of Ghana here. And I'm so sorry I missed the presentations. As you know, there's so much going on. I was hoping to slip in and listen to them. But it's an honor for me to be here to join you all in this very important discussion. Obviously, it's not merely a technical challenge. There's also a moral imperative that obviously intersects with global health, sustainable development, the realization of fundamental human rights. I've heard the statistics. Aside the fact that despite their importance, internationally controlled essential medicines are far from being ethically available in the African continent. We know that globally, opioid consumption is the cornerstone of pain consumption, but it's 50 times higher in high-income countries than in low and middle-income countries. Because the high-income countries have access and we don't. So we try the statistics about the cost that is so much that is unaffordable as against our minimum wage, which is something that is quite depressing to hear. This inequity is a result of multiple linked barriers, such as overly restrictive regulations. I'm sure you've heard that already, often shaped by the National Drug Control Conventions. And these have inadvertently limited access to internationally controlled essential medicines. Then, of course, the cultural stigma as well surrounding opioids, both at the policy and community levels, has also further compounded these challenges. The misconceptions about their use, even for legitimate medicinal purposes, detail both the prescribing and access. And then additionally, a lack of infrastructure and workforce training in many African nations. This is also an issue, but it's good to hear that there's so much collaboration at the global level, events such as these with the civil society, with government, international organizations. All of these, I think, a formidable form of collaboration that can help us have access to these medicines. But we also talk about, which of course, if people don't want to hear, we also talk about in Ghana, and of course in Africa, we also talk about something called restorative justice, where we are asking that there should be social equality. And then, of course, we talk about the fact that countries that colonized African countries should have a moral responsibility, help us improve on our infrastructure, help us to improve on how to gain access to these medications. And so these are some of the issues that I wanted to throw out there. I know the time is limited, but I'm hoping that these discussions will help us gain more access to affordable rates based on morality and equity and all the values that we talk about. So thank you all so much.
Thank you. So I will quickly wrap up. Today we learned about the need of morphine in conflicts and how to get morphine. In this case, we heard about the model drug law in West Africa. And also, we heard about the situation of availability of opioids in South Africa and the access to healthcare services in Kenya. And also in Uganda, how do they work with advocacy by the champions? And also at the end about the essential package for palliative care and how they are so important for the relief of symptoms. So thank you very much for being here and for those who are online. And thank you very much to our co-sponsor. Thank you. I hope you can.
Hello.